Okay, this is a MERS portion of ITLS training. We're going to work on IOs. So we're going to kind of talk about indications, contraindications, proper placement, proper sites. We're going to make this kind of a down and dirty. I'm not going to give you any backfill. We don't need to know where they came from. We're just going to learn how to do it and where to place them. So initially, the reason why we look for an IO is because we can't find an IV. Ideally, we want to find an IV for the hospital. Our best bet is large bore. But reality, when you got poor perfusion, you got a pale diaphoretic skin, you got someone who's diabetic and obese, you're not going to be able to find one. So at least attempt to do one for at least 90 seconds. If you can't find one in 90 seconds, there's no harm in going to an IO. Our preferred source for an adult is a humerus IO head. We'll cover placement and how to find one there. In a pediatric, I still believe it's going to be in the leg. You shouldn't do an IO on anyone under 8 or 9, especially if you can't find the landmark. So indications to do an IO is the same reasons why we should be doing an IV. You got a hypovolemic person, you've got a diabetic that you can't get, you've got someone with cardiac with poor veins, poor perfusion, it's a good idea. You got someone that potentially burned that you just can't find an IV access site due to inflammation of the tissue. You've got someone with a cellulitis or something like that that definitely needs possible sepsis, we just can't get a line on. It's a good indicator to do it on them. Reasons why we shouldn't do an IO on a perfect fight. If you see an injury on an arm, like a fracture, a buckle, there's probably not a good idea to do it that arm since it's not intact. Also, if you see some kind of scar coming down the arm, a scar cutting across the knee or anything, that means they had knee replacements or a shoulder replacement. If upon doing one there, you're probably going to hit titanium or you're going to mess them up really bad. So consider if they have scars anywhere, switch to the other side. If you can't find them up here, you can switch to a good knee or leg. Okay, we're going to go over IO sizes. Everybody knows these come in pink, blue, and yellow. Traditionally, pink is going to be our ped. They have our weight base across the top of all these tubes. This is going to be our for adult, usually the tibula. Weight base is right here. A good way to find out what size of needle you're going to need, give it a little press. When you press down on there, you're going to see how much tissue they actually have and to base that on the needle you're going to need. For humerus, even if they're skinny, big, heavy, tall, fat, you're going to want to use this one as well, the yellow IO. You can vary it to where you need to on the millimeter lines, and that's going to be your best indicator. You have enough to play with there. Okay, we're going to talk about sites. We've got sites on the legs. Everybody knows below the kneecap. You're going to feel a big flat bone through here. That is going to be your ideal target. It's easy to find. Just do probably 2 fingers below the kneecap. You're usually in a safe zone there. You don't really have to worry about any arteries, any veins, anything like that that's being inflamed. Just remember, anytime we do an IO, people have a tendency to want to drill while they're putting it in or drill before they hit the bone. Ideally, you want to press that in, the needle. You want to press it into the flesh before you start drilling. That way you know you're in the perfect spot. You're not going to twist up and bound up the flesh in there. Moving on. There's also a site in the ankle that we can hit, usually on adults and peds. Not recommended. The flow site takes a long time to do. It's something that we don't do often. We're going to talk about flow sites and how fast and how many milliliters you can go later in this lecture, but that's going to be your slowest site. But if it's all you got, it's all you got. We're going to see if this video works, but the humerus IO is as fast as a central line. Usually it takes a fluid 3 seconds or less to actually make it and go through the heart. As soon as we get down the distal, we're looking at 3 to 4 times longer, so 9 to 12 seconds to get from the humerus or the tibial fibula up to the shoulder. Your ankle is going to be 3 or 4 times that length. So let's see if we can get this to play. It's a quick, and unfortunately don't. So I will send out a link when Captain Botch comes around to do your practical IOs, and you can kind of watch how fast this goes. The next side is the humerus head. The humerus head is about the size of a golf ball. It's really easy target to find on a proper fit individual. So Mac, I'm going to have you step in here with me real quick. We're going to mask up, and I'm going to show you kind of placement and how to find this. There's a couple methods that we can use. Okay, so ideally, we've got one method, palm on shoulder, move the arm around, I can feel that ball. I know I've got him right here. There's another one, we'll have Matt put his arm there. So I'm going to come in the armpit here, I'm going to come here, and I'm going to roll up hard. I find that head, and then my head right there. So there's a couple ways to find that. Just remember, you have a long bicep tendon if you don't cross this arm across. So remember, if you're sitting at the head or a heavyset person, good way to kind of feel across, armpit, right on the medial side of the line or the lateral, and then drive up. You're gonna have to push firm and tightly, but you'll feel that head right there, and then it's gonna be on the top. Like I said, you got a golf ball size target to hit, so it's not like finding a needle in a haystack. So for proper placement, we just addressed it. We're gonna move the arm across. We're gonna use aseptic techniques. After we find our landmark, wipe it down, making sure it's good and clean. Since it is an invasive procedure, all right, we can have you take a seat, Mac. Since it is an invasive procedure, just remember, make sure it's clean. We're going right into the bone, right into the marrow. After we do that, place the hand across the body, we're gonna find it. We're gonna set up our equipment, just to normal how you would set it up. Have your gun out, your needle out, your lidocaine, your saline lock, and then your secure device. As soon as you get it in, remember, place the needle on the tip, find your landmark, drill it in. Drill until you find resistance. That's gonna be how you know that you're in. And then next thing you're gonna wanna do is you're gonna put on your safety device after you pull the needle off the top. So, like I said, move that across the elbow, and then that's gonna be the easiest position. It moves that tendon out of the way. Like I said, right here we show the ball of the hand palm method. It's an easy method to find, especially on your heavier or obese person, or if you're sitting at the top, or if they're thin and frail enough, you can be able to do this and see that head and just perfectly fine. As you can see, the hand went into the aspect of the shoulder. The other one goes on the other side. You use both your thumbs, using firm position. You're gonna see that narrow head up here, and then you're gonna hit the ball as you crease up. That way you can find your mark. You know it's on the anterior portion of that shoulder, and that's where you want to hit. If you have any problems, feel free to move the arm around. You're going to feel that ball move and rotate. Just make sure after you feel and rotate it, move it across the chest or rotate it in to get the tendon out of the way. So he marks with the thumb, so he has a good idea indicator. You can do a firm press, see a little red mark, and drill as needed. As you can see, the objective of drilling is when we drill across, we've got an objective. We want to drill at a 45 and a 45-degree angle. So our goal is to come anteriorly from this side, and the goal is to reach the other side's back pocket. So we're not drilling straight down, we're not drilling straight in, we're coming at a 45-degree angle and a 45-degree angle across the body. That's gonna be our perfect line of install. As you can see, oh no, we're good. We got easy connection. He's got his line, he's pulling it off. Crossed here, they just showed that you can do it. The thing with the conscious IO compared to unconscious IO is it's going to be painful, they're going to feel pressure. With doing that, that is what calls for a lidocaine. An unconscious patient, we just gun it and run it. You can't find an IV, you've tried for the 90 seconds or 2 attempts, we're going to do our lidocaine. Lidocaine's going to take the pain out. The problem with the lidocaine is it's going to be a slower process, so you're going to need a little time. So with our lidocaine infusion, it's a slow 40 for an adult, which is 2 milliliters, 40 milligrams and 2 milliliters is how we're going to start. We're going to flow that in over 90 seconds or a minute and a half. Then we're going to let it sit for seconds and permeate in the line, kind of numb and kind of tingle that sensation, take the pain away. If they still feel pain after that, we're going to drop another milliliter in there, which is 20, we'll make it 60. That way, hopefully, that's all the pain and discomfort is going to be taken away. We no longer have to flush these. If you're used to flushing it, feel free, but we are not required to. We want to make sure that you can push in and that you don't get resistance or a dead push. A dead push is meaning that syringe doesn't move. I mean, it doesn't mean that you missed the site. It could mean there's a problem with the needle. It could mean the bone's a little bit dense. We still need to drive it in. So with a pediatric, we're going to do 0.5 milligrams of this, I believe, and then whatever that is over the 120 seconds, and then we're going to wait. And then if they still have pain and discomfort, fussy, showing grimace, we can do half of what we initially pushed on them. So that's going to help take away the pain. My question and concern, and I talked to Captain Botch, is some people have done it with the saline lock on. They recommend it doing with the saline lock off. I've always done it with it on. We're asking for clarification. Do it how you normally do it until we figure out otherwise. So this video didn't work either, but there's a cadaver lab video that shows them putting in an IO. Shows the proper position, shows them going in, it shows start to finish. I'll send out that video as well. Unfortunately, it did not play for us. So with conclusion of the IO, just remember, try to attempt an IV first because that's what the hospital wants. If it's unsuccessful, go to your IO. Our position of preference is the humerus, and if you can't find that, the tib's fine. Just remember, on your constant diabetic patient, your septic patient, anyone that needs a line should get a line, and if you have to go to an IO, just do an IO. Doesn't mean if you miss an IO, like our ideal is we hit every IV, but do we actually? No. Do we hit every intubation? No. Occasionally there's going to be an issue with the IO. It shouldn't prevent you from wanting to do it again or hinder you from ever trying it again. It's a skill that we don't get to do often, and just review and research after a misfailed attempt, but be confident and just keep going at them. Remember your lidocaine dose on your conscious patient is we're going to start off with 40, reassess, and then do an extra 10. Pediatric is 0.5, and then it's going to be half their initial dose. Remember to secure it. Problem with securing is if we do get ROS during, say, a code, and we don't have that arm secured with either a roller gauze or something pinning across the chest, when we move, that IO has a tendency to snap off and break. It sounds horrible and it seems very invasive. If that ever does happen, just remember, try to establish another IV and inform the ER that we have a snap needle inside. As far as removal goes, removal of an IO, say for discontinuation, or we've established a line and have to pull it for some reason. You're just going to slide in your 10 cc needle. You're going to put it inside, and then it's a rotate and pull all the same direction up and out. Just be careful, it was in someone else's body and the needle is sharp. That should be it for this lecture. If you have any questions or concerns, gripes or grievances, we got a training officer, be sure to call them out on it. So thank you guys. Back.